Welcome to part one of pain. This is the introduction to the complex problem of pain. Pain is a complex topic to discuss because so many factors can affect how a person perceives pain. Pain is also the most common reason people seek healthcare, and it's a major thing that affects nursing responsibility. According to the International Association for the Study of Pain, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. According to Margot McCaffrey, who is known as the guru of pain management, pain is whatever the experiencing person says it is, existing whenever and wherever the person says it does. Both of these definitions together show us the pain is personal and subjective, and it is going to be influenced by things that can occur within and around the person experiencing the pain. Pain can be influenced by genetics, psychosocial situations, age, and cultural factors. So some of people's responses to pain will be learned through their life experiences and what they see around them. This makes pain an incredibly individual experience that may even differ for the same person at different times in their lives or with different situations. Because of this, the patient is going to be the most reliable indicator of pain and essential component of the pain assessment. The exact mechanism of pain has been researched for many years, and the most commonly accepted theory about pain is the gate control theory of pain. The gate control theory of pain describes the relationship between the painful stimuli, transmission of that pain signal through the nerves, going to the brain, where then pain is sensed. The gate control theory says that the brain can only accept so much stimuli, and when it receives too much, part of the spinal cord will stop the stimuli, like closing a gate to stop something from moving. They got this theory by researching how people will instinctually start rubbing a spot that hurts, and when they're rubbing, the pain lessens or goes away. The brain can only take in so much stimuli, and the pain and the rubbing together is too much at once, and the pain lessens or stops. The theory also believes that emotions and past experiences and learned behaviors can open and close those gates. Kind of like saying mind over matter. If I tell myself it doesn't hurt, I can make the pain go away. Or if I tell myself it's the worst pain ever, the pain gets worse. This theory is great, and it definitely helps us healthcare workers treat pain, but there's so much more that goes into the transition of pain that we need to discuss. The ability for the body to be able to feel pain and feel painful stimuli is called nociception. Nociception and pain are not the same things. Pain is what the person feels if the body has nociception. Nociception has 4 physiological processes to get the painful stimuli to the brain and back to the location to actually allow us to feel the painful stimuli. Knowing the 4 processes will help healthcare providers treat pain, as each process has things we can do to help the pain. The first step in the pain process is transduction. Transduction is the activation of the pain receptors called nociceptors, which are free nerve endings found in most tissues of the body. When the nociceptors are damaged by thermal, chemical, or mechanical means, they stimulate the release of neurotransmitter chemicals. These chemicals are bradykinin, prostaglandins, and substance P. These chemicals elicit the inflammatory response, excite the nociceptors, and convert the painful nerve impulse into electrical energy or an action potential. The second step of the pain process is transmission. This is when the pain cessation, the action potential, moves along the afferent or sensory nerve pathways to the brain and spinal cord. We have fast-moving nerve pathways like our A-delta fibers and slow-conducting C fibers. The A-delta fibers usually transmit the sharp, localized pain from mechanical or thermal stimuli. C fibers typically transmit the diffuse, dull, achy pain from chemical and persistent mechanical or thermal stimuli. The A-delta fibers, being those fast transmission fibers, are responsible for the protective response we have to pain. The stimuli is transmitted rapidly through those 8 alpha delta fibers to the brain, and the brain sends a signal back down the motor neurons, and we have an immediate muscle contraction that makes that injured body part pull away from the pain. Think of touching something hot with your finger. You touch it, and within a second or two, you pull your finger away from the heat. The third step of this process is perception, actually being aware of the pain. Perception of pain is where the process is very individualized. We don't all perceive pain the same way, even if it's the same pain being inflicted upon us. This is where a person's pain threshold comes into play. Pain threshold is the minimum intensity of a stimulus that is perceived as painful. How much pain stimulus can cause a person pain? And we all have different pain thresholds, and the threshold can be different with different types of pain. And the last step in the pain process is called modulation, or the inhibition or modification of pain. This is how the body reacts to the pain to lessen what we're feeling. The body will release neuromodulators, chemicals like endorphins and enkephalins and other things to alter the perception of pain, and they make the pain feel better. We learned about how pain is individualized and how it occurs. So now let's look at what affects how a person perceives pain. There are many factors that affect how a person perceives pain, and the factors may change throughout the lifespan and life situations. The first factor we will discuss is culture and ethnical backgrounds. This does include genetics, biological sex, gender, and age. Cultures have different thoughts on pain and the cause of pain and how pain is expressed. Some cultures express pain very dramatically, with wailing and crying and screaming, and some cultures remain silent and stoic, not expressing any pain. Both of these cultural norms will perceive pain differently because that's just what their culture believes. The culture may also dictate how pain is treated. Genetics may affect the person's sensitivity to pain, causing more or less pain than expected. Biological sex differences with hormones and how society treats the different biological genders can affect pain. Many biological males are told they cannot cry or show emotion, and that translates over to pain as well. Many biological females are told they express their pain and emotions too much, so their pain isn't taken as seriously because they're just overreacting or they're being too emotional because of the pain. Age alters how we perceive pain, and that's going to change through the lifespan. As we get older, the elderly may have more than one source of pain. The elderly may not report pain due to fear of it's actually a disease and maybe they're dying. They get scared that they're going to become addicted to medications, and a lot of them think that pain is just part of getting older. Different religions perceive pain differently, which will affect the individual. Some religions believe pain is a punishment or that they weren't good enough in their religion. This can cause emotional pain, which can trigger anxiety and fear and sadness on top of the physical pain that they're already feeling. Sometimes emotional situations can cause pain when pain wouldn't typically be present. For some people, the environment they're in, not their physical environment, but who they live with, what's occurring around them, the support system they have, is going to affect how they perceive pain. Do they have a strong support system that helps them through the pain, or do they feel more pain in an effort to get some support? Did they learn how to perceive pain from people in their environment? Were they told to express pain or to bury that pain and not tell anyone? Past experiences will affect how a person perceives pain, especially if they had a bad experience with pain relief in the past. Some people can compare the pain against something else that caused pain in their life. Like I had a kidney stone, and I can absolutely say for certain that pain was worse than giving birth to my child. And then we have people out there who will anticipate pain, so they even experience pain before that painful stimuli even occurs. Because the pain perception is so person-specific, the response to pain will be as well. People respond to pain in 3 ways: behaviorally, physiologically, and affectively. Behaviorally is our voluntary response to pain, moving away from that painful stimuli, grimacing or moaning, or protecting that painful area. These responses can be learned from others around us. Our physiological or involuntary response includes changes to our vital signs, muscle tension, becoming pale and diaphoretic. We can become nauseated or vomit or even faint from the pain, and we have no control over these responses. Our affective or psychosocial responses can include wailing, being stoic, depression, fear, anxiety, anger, insomnia, and a lot of these responses can be learned from others around us as well. There are several different types of pain, and we can classify pain several different ways, but the first way we classify pain is by length of time the person's had the pain. If the person has new or rapid onset pain that lasts less than 6 months, they have acute pain. Acute pain typically has a known cause, an event, some sort of internal disease, or an external cause that's causing the pain. The external cause could be an injury, surgery, or trauma. The pain can be very intense, and the duration is usually short-lived. It goes away. It will go away, continues to get better. And a lot of acute pain is protective in nature, meaning the pain is going to stop us from doing something that's going to make it hurt worse. Like I said, acute pain tends to get better over time as that cause heals itself. Acute pain also has visible signs and symptoms as well as sympathetic nervous system responses. We can see crying and screaming and grimacing, as well as those vital sign changes, diaphoresis, shaking, even that nausea and vomiting. We can further classify acute pain into different types of acute pain. The first type we'll discuss is nociceptive acute pain. Nociceptive pain, or physiologic pain, is the normal type of pain we think of when we have an injury to tissues. Nociceptive pain can be somatic or visceral. Somatic pain is from damage to the tissues like skin, bones, joints, so it can be superficial, like on top of the skin, or it can be deep within, like a joint space or after surgery. People can typically localize somatic pain, meaning they can point to the spot it hurts. Visceral pain is pain that's coming from an organ, from damage or ischemia, which is lack of blood flow, obstruction or inflammation, or even a tumor. It's coming from deep inside an organ. A heart attack that causes chest pain would be considered visceral pain. Or appendicitis, that appendix becomes inflamed and infected, that would be visceral pain. Visceral pain is harder to localize, and it may have other symptoms depending on the cause. Referred pain is a type of pain where the pain is felt in a part of the body that is different from where it's actually occurring. Take a look at this picture. The picture shows that pancreatitis, which is a Block 3 topic, typically has pain in the left upper shoulder, but the pancreas is nowhere near the left upper shoulder. Another common referred pain you'll see is left arm and jaw pain with a heart attack. The heart isn't in the jaw or the arm, but that's where the pain is commonly felt. Referred pain is different from radiating pain. Radiating pain is occurring at the point of injury or disease, but the pain extends from the initial site. People with back injuries also often have pain that radiates down their legs or up their back, even though the site of the injury is in the back. Shoulder injuries will radiate all the way down to the tips of the fingers, even though that injury is in the shoulder. Next, we have neuropathic pain or nerve pain. This type of pain is not beneficial, meaning it's not trying to protect us from injuring or hurting ourselves more. Neuropathic pain is caused by abnormal sensory processing by the central nervous system or the peripheral nervous system. Somewhere there is damage or dysfunction of the nerves that may be occurring due to tissue damage or inflammation, like if you had surgery and they cut a nerve, or it can occur when no tissue damage is present. This type of pain can be described as burning, throbbing, shooting, or tingling. And some common causes of neuropathic pain are from diabetic peripheral neuropathy, fibromyalgia, and migraines. The treatment of neuropathic pain can be very complex, requiring different types of medications to treat the pain and to calm the nerves. And many times it can't be controlled in 6 months, so it doesn't always stay acute pain. It will turn chronic. Which leads us to chronic pain. Chronic pain is different from acute pain in terms of the time frame. Chronic pain is going to last longer than 6 months, and it's not a beneficial type of pain, meaning it's not protecting us from anything. It may occur for years, or it may never resolve. Chronic pain may start suddenly and acute, but it doesn't go away in the normal amount of time and may be intermittent or continuous. It's not uncommon for people with chronic pain to have periods of time where the pain gets better, we call that remission, and then have periods of time where it gets worse, called exacerbation, or we may see breakthrough pain. We don't typically see visible signs and symptoms of chronic pain like we do with acute pain. They may have poor sleep, they may be fatigued and irritable, they may not want to eat, they may be angry, they may self-isolate themselves, and they may become depressed. These patients are the most likely people to be called drug seeker because they'll search out treatment for their pain until a treatment can be found, or they become so depressed that they turn to an alternative like suicide as their only option to end the pain. And most neuropathic pain, that nerve pain, is going to turn chronic. People with chronic pain can have acute pain at the same time. So someone with chronic pain can have surgery, and that adds acute pain on top of the chronic pain they already always feel. This can be really challenging to treat because many healthcare providers are hesitant to prescribe pain medication for acute pain to someone who is taking pain medication for chronic pain. And as nurses, we've got to advocate for our patients to make sure that both types of pain are being treated, as they have different causes and different treatments. I just added this little chart here to this slide to show the differences between acute pain and chronic pain for those of you who like to see things side by side. And here are some common myths about pain that are important for you to know as a nurse. So first, pain has a physical cause. That's a myth. Pain has both a physical and mental component. The caregiver's values and beliefs determine the patient's pain management. That's a myth. Only the patient has the authority over his or her own pain. The more pain one experiences means one has a greater pain tolerance, and that is a myth. Pain tolerance usually decreases with time. Addiction occurs with around-the-clock pain management. That's a myth. Addiction only occurs in less than 1% of patients. Medicate infrequently with the smallest possible dose. That's a myth. Bring pain medication before that pain cycle begins or advances is going to control the pain better, and we'll talk about that in another PowerPoint. Pain helps healing. That is a myth. Pain actually hinders healing by affecting mobility, oxygen consumption, and circulation. Acute pain is worse than chronic pain, and that is a myth. Chronic pain is harder to treat than acute pain, and it persists for months or years or always. Children, sleeping, and comatose patients don't feel pain. That is a myth. Children experience pain, but they're easily distracted, and people who are sleeping and comatose both experience pain. And lastly, the elderly have less pain. That is a myth. Elderly complain less, but they have greater amounts of pain due to weakened body systems. And this is the end of part 1, and I'm going to end this with something you're going to hear a lot in your career as a nurse, and that is, I just want the pain to end.